Hi guys, sorry. I'm Amy Blazik. I am a physician assistant with the palliative care team.
Hi, and I'm Sandra Sherpareel. I'm a nurse practitioner with the palliative care team.
And we're doing things kind of wonky just because our desktops don't have mics or cameras, sorry. And so I will be sharing the screen with you guys, and then we're just talking through the phone. So sorry, it's a little bit awkward.
We're gonna make it work.
Yeah. So we have just a presentation that we put together. So we're hoping that it can be helpful and just kind of helping teach you guys when to call us, some conversation starters, that sort of thing. So if I can get this to work.
And we may rush through the presentation a little bit because I think Dr. Creed said something about 30-40 minutes, and it's a little bit longer. So some of the slides we're going to skip through.
So obviously, and I hope that everybody knows the active signs of dying. Obviously decreased urine output, cold and mottled extremities, vital sign changes. People will have Cheyne-Stokes breathing or apnea, respiratory congestion, or kind of the death rattle, terminal delirium or confusion, which is really often seen or identified after the patient's died. A lot of the times they'll have delirium right before, and then they'll end up passing away, and you're like, oh, that was terminal delirium.
And restlessness. No, yeah. Go ahead, Amy, sorry.
No, you're good. So just signs of active dying. We as providers don't focus on death often. We focus on living and treating and curing. And so it's important that we recognize the signs of active dying, just because it's something that's going to happen to all of us.
And when we say actively dying, we feel like we're dead. That's usually about a 72-hour window. And obviously sometimes you're going to see some of these signs like mottling in your ICU patients that are on pressors, and it obviously may not mean actively dying, but sometimes obviously when it's coupled with these other things, then we really start worrying about that as well.
So communication is really important as a provider and between different teams. Obviously we are a consulting team, so we never take over as primary. So a lot of the times you guys will be primary and you will be consulting us. It's really important that we as the team, as the consulting team, gets a good picture of kind of what you guys feel like the prognosis is and what you have communicated to the patient or the family, what that prognosis is. Because it's difficult for us to go in and have the prognosis discussion because we're not the primary team. And sometimes that's a job for oncology or surgery or a different team. But I think as you guys are the quarterbacks, a lot of the times that'll be one of our questions to you is, what have you told the patient about their prognosis?
And oftentimes the very first question that we ask patients and families is, what are the other teams telling you? What is the primary team telling you about, your disease process or what's going on with you? So that's our first question to them. And every now and then we get well, they're not saying anything. But obviously, and then sometimes they're very good. They're very worried, or they tell me my prognosis is grim, or I'm terminal, or today my patient just said I'm dying. But we always use the spikes protocol. And this is something that y'all can Google, and if y'all have ever spent any time with us, y'all will get to know spikes very well. And I've noticed several of the interns and some of the people that I've worked with, y'all are using this very well. But of course, the first one is setting. That's making sure the right people are there, making sure the patient is comfortable and not in the middle of eating and things like that. Definitely sit down to talk to the patient. But sometimes there can be too many people in the room. We need just the people that the patient needs there for support and to help them make decisions. And then of course the P is perception, like we talked about. That's our first, in any family meeting you go to, once you introduce everybody, that's the first thing that you should ask the the family and the patient is, hey, what is your perception of what's going on? Tell me what you know about your disease process, and what are the other doctors saying about options. And I was going to say something else about perception in the family meeting, and I know part of this too is you'll learn a little bit about the patient's capacity, but if the patient is able to say, gosh, I've got 4 organs that aren't working, my heart isn't working, my lungs aren't working, and you're like, okay, yeah, you've got it.
So the I is for invitation. Honestly, it's not one of my strong suits, but asking, is it okay if we talk about this right now?
But it's a really important thing to do, because the patients have lost so much control that if you ask permission to, hey, is it okay if we talk about some hard stuff? Or so every now and then you'll get a patient that says, no, I don't want to talk about this. You go talk about this with my wife. We'll talk about it later. And so sometimes I'm sort of shocked, but I would say about 95% of the time the patient will say, yeah, no, it's okay to talk about it. But it also is a bit of a warning shot. They know something, we're about to talk about some hard stuff.
Right. The K is knowledge. And so after you get their perception of kind of what's going on, then a lot of the times we'll say, it sounds like you have a really good idea of the entire situation. There is, this is kind of what I understand. This is often the time of the meeting when you as the primary team, if you're with us, like we'll kind of look to you to give them a little bit of just the medical knowledge. But I say that because we don't want to overwhelm them with medical jargon. We don't want to go into really long, extensive, what if scenarios and things like that. It just needs to be simple, and it needs to be to the point and direct. The E is emotions and empathy. So kind of emotionally aligning with the patient or the family. I see this is very hard news. I see you're very sad. I see you're angry, something like that. And then always end it with a summary in kind of what the plan is. So a lot of the times it's, okay, so we've talked about this, and you guys need to think about things and talk about things as a family. And we're going to meet again on Tuesday, or we're going to meet again. And, you guys are going to talk about some of these things, and we're going to go from there. So going back to kind of what we said, communication with the teams is super important. Y'all remember that a lot of your communication is nonverbal. And so that's why we say it's important to sit down. It's even in this COVID world, it's important to touch people or to acknowledge, introduce yourself, those types of things.
I think that one of the biggest things on this slide that's important, and probably one of the most important things I've learned in palliative care, is you just have to be really honest and transparent. And sometimes it's like your gut is telling you, oh, I don't want to tell these people that I think their person is down to days of life, but you have to, for them to be able to make some very difficult decisions. So sometimes that whatever's swimming around in your head, that I really need to tell them that I'm so worried about them, that I'm worried their person isn't even going to make it out of the hospital. And you have to say, hey, I've got to be honest and spit it out.
Mm-hmm. And that really helps kind of manage the patient expectations. Like if you're saying, I'm very concerned that my loved one isn't gonna, I'm very concerned that your loved one isn't going to survive the hospital stay. Hopefully that helps to kind of get everybody on the right track.
I'll oftentimes too say, hey, the primary team tells me they're worried about you. Mm-hmm. I've just spoke with the nurses, and the nurse that's had you the last 3 days, she's worried about you. She's really seen a decline. Those are I think the word worry and concern those mm-hmm. are good words. And Amy and I always use things like, well, hoping for the best and preparing for the worst is kind of some of our terminology too that we use.
So we kind of talked about that. So I think this slide, the biggest thing is this warning shot. If you guys are going to go in and you're going to have to tell a family and a patient that maybe they have cancer, because they had a biopsy 3 days ago, it's always important to kind of give them a warning shot. And so to say, I have some really bad news. Is it okay if we talk about this right now? And that like Sandra said, kind of gives control back to them. Yes, this is an okay time, that sort of thing. So that's really important.
Well, and also just make sure your nurse knows. If nobody's there with them, the nurse can be there also. I mean, make sure they have family there. If you can get family there, if you know you're going to be given this bad news too.
Yep. So this slide just kind of has a couple of things that we don't like saying. Please don't ever tell your patients that there's nothing more that we can do. You might say there's nothing more that we can do to treat your cancer, but there's always something else that we can do to focus on your comfort, or you're dying with dignity or something like that. So there's always something that we can do. So please don't tell them that there's nothing more that we can do.
And I know several of you have seen this slide before,
Yes.
but this is probably more for the interns. So
please don't say starve to death. Your families may say that to you when you're talking about artificial feeding. And we always just kind of have to say, you know, we think of starving as when we are withholding food from someone who is hungry. Whenever people get to the end of their life, they're not as hungry. They are not usually requesting food because they may be down to hours or days. And so it's a very normal process. So we don't think that we are starving the patient by not giving them artificial feeding.
And that's a very appropriate time, if they're bringing that up, to talk about pleasure feeding with the known risk of aspiration. And getting our speech pathologists here at this hospital are fabulous at talking about all of that. And they're actually even good at going to family meetings with you if there's a big, you know, if you feel like that subject's going to come up, because it's kind of a hard subject, obviously. But
yeah. Suffocate is another word that you may hear. We like to say air hunger just because suffocate sounds so bad. Please don't say, well, they can go to hospice, or they can just go to the hospice floor. So hospice is a service, it's not a place. And like this third floor supportive care unit, it's a place within the hospital, but it's not somewhere that they can stay long term. And then the bottom one, we used to always say we're going to withdraw care, and the thought process has changed. And so now we're saying we're going to remove artificial support. And that just sounds a lot kinder than withdrawing care. We say, I wish that there were better options all the time. And so that's something, you know, if you're struggling with kind of what to say, like you could say, I'm so sorry, I wish that there were better options available for you, or something of that nature. Oh no, hold on, I gotta find it. Don't know where it went.
is it there?
Ah.
Oh, you found it.
Okay, sorry.
Technical difficulties.
But
I think too, like back with the emotional alignment with the family meetings, I think it's always very appropriate at the beginning of the meeting to just say, gosh, I'm sorry your loved one is in the situation they're in, and I'm sorry your family's going through this. And that's an okay time to say, I'm sorry, you know?
Yeah. It sounds like you guys are going to be getting some code status and DNR education.
I'm going to hit a little bit on it. And then I think there's sounded like it was more through the legal department, didn't it sound like? But I'll run through the DNR stuff pretty quickly. DNR should always be talked about in the larger context of what the patient's goals are. And in order to have a good DNR discussion, the patient does need to know their prognosis. They need to understand their disease process. I don't know how many times I talk to families and the patient may be on oxygen at home for their COPD, and they don't really realize that they're at the end stage of their COPD. And so sometimes it's just a lot of education leading up to a DNR discussion, and them having some sort of understanding that they have a limited prognosis or limited life expectancy. So they should always have a good understanding of what's going on. Same thing back to the spike stuff, establish a good setting, make sure the right people are there. I think CPR in the hospital, people really need to understand that the hospital associated with very poor outcomes. Arrest in the hospital is usually associated with advanced illness versus a reversible cardiopulmonary situation. Only 15% of people, and that's like 1 in 6 people that undergo CPR in the hospital actually survived a discharge. So that's a pretty low number. The things that contribute to a poor outcome with CPR include sepsis, creatinine greater than 1.5, metastatic cancer, dementia, and dependent status. So those are all things that, and it's okay as a physician, it's okay for you guys to say, we wouldn't recommend you going through this. We think this is going to cause you more suffering. So it's definitely okay for you to make recommendations about it. I do want you to make sure that y'all are having the conversation and giving people options. First option is we find you without a heartbeat, you're dead. We can make an attempt to reverse your death with CPR and putting you on a life support machine, and use life support instead of vent, because vent doesn't sound like that big of a deal to people. But use the word life support. That's your first option. And your second option is, no, I'm already dead. Leave me alone. Let me die comfortably with dignity without putting me through all of that. Respect their decision. The best thing to do too is present those things to them and say, hey, I'll come back tomorrow and you talk it over with your family, think about what you want, and then we'll revisit this conversation tomorrow. Don't expect them to have the answer right then and there. I'm obviously y'all are in situations where they're about to have a tube bit down their throat at any second. I think in those situations, please try to avoid saying things like, do you want everything done? Because everybody's going to say, yeah, I'm going to sign up for everything, or your other option is, no, you're dying. We're going to keep you comfortable.
I think
we should probably skip.
I think, yeah. So there's a difference between hospice and palliative medicine. So our team, the palliative team within the hospital, Dr. Kelly Klein, which you guys know, or hopefully if you don't know, you will know, Dr. Lux, and then Dr. Gates are our attendings, and then there's Sandra and I, and then we have a nurse coordinator, Jessica, who answers our phone. And so we're the palliative team. All hospice is palliative care, because the word palliate means essentially to relieve suffering. And so whether that suffering is physical with pain or nausea, whether that suffering is emotional or existential, the goal is to help relieve suffering. So all hospice is palliative care, but not all palliative care is hospice, because we see a lot of people who are still actively seeking aggressive treatment for their cancers, and we are seeing them for palliative care to help manage symptoms and pain and nausea and those types of things.
And I think it's, that may be one of the good ways for you guys to introduce this to that our team is coming to talk to them. You might even just say palliative is a weird word, but the word actually means to relieve suffering. They're great at managing pain. They're good at talking about advanced directives and kind of talking about, we have a complicated thing going on, and let's talk about pathways moving forward and what kind of things you want for yourself.
Right. And now there is also a difference between palliative comfort care is kind of the whole,
we think of comfort package. Well, comfort care we think of as just those last few days of life where we're really only giving medicines for comfort, like pain and symptom management. Now, more of a palliative path, you would be thinking about maybe they're getting chemo, or maybe they're getting radiation treatment, or maybe they're getting antibiotics for their pneumonia, but they've decided to go home with hospice for their COPD, but they still, even on hospice, you're going to get antibiotics and breathing treatments and steroids and all those things. So that's more of a palliative, if that makes sense.
Right.
Yeah.
And I think a lot of people use palliative care and comfort care interchangeably. And I guess my point is it shouldn't necessarily be interchangeably. Comfort care is usually the very last several days of life. So in the hospital, like I said earlier, we're consult service. Outside of the hospital, we would, if their goal was palliative, to be on palliative care outside of the hospital, then that's where hospice would come in.
We do have Dr. Lux and Dr. Gates do have a palliative clinic
mhm.
in the cancer center where they treat people. Most of the consults, I think, are related to pain management, and those consults are for somebody that has a chronic disease or potentially a terminal cancer.
In order for somebody to qualify for hospice, basically the physicians ask themselves, would I be surprised if this patient died within the next 6 months? If your answer is no, that wouldn't surprise me at all if this patient was dead in 6 months, then it might be a good opportunity to start working to introduce the palliative team to start having some of these discussions, or yourself have some of these discussions with patients who may be nearing the end of their disease processes.
And if you have any questions about like what qualifies somebody for a hospice based off of like kidney disease or liver cirrhosis is one of the harder ones. I think oftentimes people think people will qualify, but you have to be pretty darn sick with liver,
And
but
dementia.
we have a lot of those resources at our office, and we're happy to help.
So just really quickly, there are 4 different levels of hospice care. Hospice at home, routine home care is the main level of care. There's continuous hospice care that doesn't happen very often. It just doesn't happen very often. There is inpatient hospice care, and that is when it's called general GIP or general inpatient population. That is basically when the hospice company feels like the
hospice medical director
feels like the patient cannot be controlled, whether they're having pain or nausea or some symptom cannot be controlled under routine home care. And so if we're having to adjust their pain medicine, if we're having to do lots of nausea medicine for patients or things like that, then they might be a candidate for GIP. However, that is not something for you guys to call or decide. It's not something for us to decide. It's up to the hospice medical director. And then there's respite care. That is a Medicare provides respite care for several days during a 30-day period so that caregivers and families can kind of have a little bit of a break.
Okay, I think you've already kind of gone over that.
Yep.
And then I don't think we have time to go through all the artificial nutrition. If you guys had specific questions, I want y'all to be able to chime in at any time. If y'all have a scenario that you've had recently that's been a tough one, or anything like that, we're happy to talk about it. We do have some great articles because families do struggle over IV hydration, artificial feeding. They struggle with when it's time to kind of shift focus to a more palliative route or a comfort route. They struggle with that. And so we have a great article, and we've just been having the conversations a long time. So I know it was a hard conversation when I first started doing this job, but we're happy to help with those conversations too.
So one of the questions is, when is it appropriate to consult our team? I think if you have patients who have chronic illnesses, whether that's COPD, heart disease, cancer, liver failure, kidney failure, dementia, any of those, and they are maybe frequent flyers, maybe they're bouncing back,
maybe they're early in their diagnosis, and we can just kind of go in and ask them about their advanced directives and if they've got their medical power attorneys in order and what they want for advanced directives and DNR discussions and some of those kind of things, if they what they want.
Yeah, I think the irreversible stuff, the strokes and car accidents and like trauma stuff, that stuff is a little bit harder. But certainly if you have somebody who has a prolonged hospitalization and if your gut tells you that things are not probably going to go real well, then you may want to start thinking about getting us involved. Like I said, multiple hospital visits. I think if you're just your intuition, I think a lot of times we want you guys as the primary team to have conversations with the patient or the family about us coming in. And so a lot of the times like Sandra said, you can say, hey, we have this team, and they can be really helpful with your symptoms. They can also talk about some of the planning for the future, those types of things. And so just kind of give them a heads up that maybe, you know, we would like to come in and kind of visit with them. I think kind of the thought process to this slide is, you know, we want to work as a team. We want to come alongside you guys as the provider, as the primary team. We want to try to help you, help the patient. And so we certainly don't want to step on toes. We just want to provide the very best care for the patients that we can. And so, you know, we work really hard to communicate well with you guys and to say, hey, are you okay if I order so-and-so, or, you know, that sort of thing. So,
well, and I think back to the introducing us as a team, I think anytime things are kind of hard for you to talk about with people, normalizing the process is very good. Like, well, this is kind of the team that we normally ask to help us at this time, or even if you're in a tricky situation with a patient and you feel like, gosh, you feel like it's just hard to talk about things, or they're complaining about things, just say, well, this is kind of a normal thing that happens when patients are in the situation. I don't know if that was helpful or anyway.
well, and I think a lot of the times too, the nurses, we've done a lot of nursing education as well. And so they may approach you and say, hey, how do you feel about a palliative consult? You know, I've kind of been talking to the family or things. So a lot of the times the nurses may approach you about a consult too. So just kind of keep that in the back of your head. This is really important, and I don't know how much of this you guys get. So if there's not a medical power of attorney in the chart, then this is the order that the surrogacy, the decision-making capability is. So if there's not a medical power of attorney, then it automatically goes to the spouse. If there's not a spouse, then it's a consensus of the reasonably available adult children. It is not the oldest child. It is, you know, it's not the oldest brother. It is a consensus of the reasonably available adult children. If there are no children, then it would go to parents, and then it would go to siblings of the patient, and then its nearest living relative after that. We very rarely get to that point, but we have before.
Do y'all have any questions about this slide or surrogacy?
It's kind of hard on Zoom.
It is hard on Zoom.
A medical power of attorney is a legal document. And so if somebody tells you, oh, well, I have medical power of attorney, my first question is, oh, that's so great. Do you have a copy of that I can scan into our system? Because if they say they have a medical power of attorney, but we don't have the document, they don't have a medical power of attorney.
And y'all probably all know, all of these things are under the advanced directive bucket in the chart. Mm-hmm. And so, but sometimes, like the other day I had one that I had to scroll back to 2004 mm-hmm. to find, so sometimes they're actually there. You just have to scroll back, and even like the DNRs, sometimes you'll have to scroll back for, and the advanced directives. So I hope that makes sense when I'm saying scroll back the time bar.
We have a comfort care plan that is in the computer for you're more than welcome to use if you have a patient who is ready to just focus on comfort and be comfort care
and is being compassionately extubated, what mm-hmm. have you. A lot of times it's good whenever someone's like weaning off a high flow too, because the morphine and the Dilaudid and the hydrocodone, all of those are, you know, like in 15-minute increments. But and like one little note on that too, if you're putting somebody on comfort care, pick your opiate, pick one opiate. Don't pick a scattered, you know, opiate situation. As long as they're not in kidney failure, you know, morphine's a good first choice. Or if they're already on a fentanyl drip, mm-hmm. just keep them on the fentanyl drip and use that as your opiate.
Yeah. But if you guys, so if y'all are in the ICU, you are welcome to use that comfort care set. A lot of the times, and especially here recently, we've had patients on really high PEEPs. And so it's important that if you have somebody who's on a lot of oxygen and a lot of PEEP, that we will wean them before we extubate them. If not, sometimes the extubation can be really awful and we don't want that. So a lot of the times we'll wean them down and make sure they're comfortable before we even take out the ET tube.
And I always kind of struggle because I've always talked to the family about this and tell them like, hey, we expect that the patient's going to start dying before we even get them off the vent, but this will help them not have air struggle when they're coming off the vent. And we did one the other day, and I think her FiO2 was almost 100 and her PEEP was, gosh, in the 20s. And we were able to get her off still fairly quickly. And they just adjusted the fentanyl as she went, and it was okay. But when you do it, if you just extubate on high PEEP and high FiO2, it's really ugly.
And I think the one thing at the bottom, number 5, so you really should titrate your opiates, whether it's a fentanyl drip or morphine pushes or whatever the case may be, you should titrate the opiate to the patient's respiratory rate. And so we traditionally say we want patients to be breathing less than 24 or 25. And if they look uncomfortable, then give them a dose of opiates.
And obviously, sometimes you have a patient, he's only breathing, 18 to 20, but they're using so many accessory muscles and their shoulders are lifting off the bed. So you're going to go by that more than the rate, obviously.
Depending on the situation, oftentimes if it's a true comfort care and we're actually removing artificial support, we just go to either 2 liters nasal cannula or just room air. We don't do the whole BiPAP or high flow or any of that.
And I a lot of times ask the family, hey, were they on oxygen at home before all of this? And if they're your lung patient or your heart patient, I feel like that's a really normal time to just leave them on their normal oxygen unless for some reason it's bothering them.
So that's pretty much all that we have. That was a lot of information really quickly. Does anybody have any questions or concerns or anything that?
I think I wanted to throw one last thing in that I kind of put down under my DNR notes. It's really good if the patient is able to have the patient sign their own DNR. I've had situations where maybe the patient's really weak and then the wife is in their room and she'll say, oh, I'll just sign it. But you know how it is. Sometimes every now and then you'll have a patient who doesn't sign their own DNR. Well, they want to be DNR, and then suddenly maybe they're less responsive and family wants to flip the DNR. Well, you can't flip the DNR if the patient has signed it himself, or herself. So that's just a good kind of rule of thumb. And it sounds like you'll be hearing a lot more about that with your upcoming DNR discussions. But we're open for questions if y'all have questions. I think one of the things that Dr. Creed had asked us to talk about was, how you can cope as a provider with the loss of your patients. And so I think a lot of that is the normal stuff like self-care and taking time for yourself, but it's also okay if you cry with your patient. I think the rule there is just don't be crying so much that they're having to console you. But it is okay to show some emotion with your patients.
And Dr. Abbott brought up a really good point. So we've got 2 fellows, Dr. Abbott and then Dr. Murillo, and they're with us this year to learn more about hospice and palliative medicine. So they're available as well. So you guys may see them.
I'm sorry we didn't introduce them with the team.
Sorry, Dr. Abbott.
Amy, I had a question. Thanks for the talk.
Yeah.
How do you approach, because sometimes I see for example, the girlfriend of the patient is in the room taking decisions. How do you kind of tell them that, probably they're not the best ones to be taking those decisions, even though, they have a close relationship? Thank you.
I think what we, I'll be very honest. Usually we say, hey, so we feel like you should totally be a part of this decision. But maybe it's the mom or whoever, let's say it's the mom that's actually the surrogate decision maker, but hey, like John's mom is actually the legal decision maker, but we always encourage families to get together and make this decision together. So everybody's on the same page and we're all being super thoughtful about how to move forward with this care. So and hopefully the mom and the girlfriend get along. Obviously that's a whole other, they don't get along. if they don't get along, we just try to, like, hey, we need to preserve your feelings too. Hopefully we're all thinking the same way. We're being thoughtful about his care and what he wants. Did that help? Or
Yeah, thanks. I just needed an example. Thank you so much.
A lot of the times we just say, well, in the state of Texas, like, this is the order. So do they have, is your girlfriend, but you're not legally married? Okay, what about adult children? Are there any children? And then you just kind of go down the list and see who would be the decision maker, and then say, ultimately, our goal is that everybody is on the same page. And most
of the time, a lot of those complicated situations clear up with a family meeting, because when they all get there and they have to kind of stare at each other, and we're putting a lot of emphasis on, you better make sure this is about the patient and not about y'all and what the patient wants. Yeah.
Thank you.
You're welcome. Anybody have anything else?
Yes. Hey, Sandra and Amy. Thank you for the talk.
Hey.
I'm Barbara. How are you? 2 questions. So one of them, I'll put the video on. One of them is, what about a hospice compatible with dialysis at all?
That's a tricky one.
Yeah.
We have a really, and even the physicians on our team have differing opinions about that. I was sort of raised in palliative care where it wasn't usually very compatible. I did have a cancer patient once, a young cancer patient who, in my mind, she got cisplatin and it knocked out her kidneys, but she had a gynecologic cancer, and then later her kidneys were bad. I think she actually stay on dialysis until her kidneys progressed worse. But for me, it's hard not to link the primary diagnosis to kidney failure, because it almost, it's almost always like they're on for heart failure. Well, their kidneys are bad because of heart failure. But there's some rare cases where you can do dialysis with heart failure. It's hard. Like Dr. Klein and Dr. Gates are not fans of it. I think it's too hard with Medicare. It's just really tricky. Now, Dr. Lux, he's very much like, he thinks it's something that can be, it can be done.
Right.
And so we just try to stay neutral on it. If a scenario pops up where we feel like it would work, then that's great. But most of the time, your hospice diagnosis, you can blame the kidneys on it too.
So I think, like, Dr. Lux will tell you that if there are 2 separate diagnoses, so if they're on hospice for cancer, and then they have, renal disease or whatever, if there's 2 separate diagnoses, then they can do it. But I think in reality, it doesn't really work.
I think I could see it if the cancer, like if maybe somebody had chemo that did not knock out their kidneys, like it was just they had a terrible cancer and their kidneys were just, they died all on their own kind of thing.
Yeah. So.
Thank you. And the other question was, do you have any tips when you're discussing with family members and, the patient wants something, but the son's daughters want something else, and there's kind of like a conflict there?
I usually just try to get everybody in the room and ask the patient and say, hey, you're going to have to tell your people here, sometimes you don't even have to tell the patient that. You just have the conversation innocently, asking the patient, like, what do you really want? And just encourage them to let the patient talk. And, and once they hear it out of their loved one's mouth, we're like, hey, we have to honor that. We have to be really thoughtful about this, because you don't want them to suffer and you don't want to feel like you've pressured them into something.
And I do think a lot of the times, whenever it's like push comes to shove, the family is going, a lot of the times, not always, but a lot of the times the family will say, well, Mom, it's whatever you want to do. Like, we support you, even though that's really not what they feel in their heart, that they really want Mom to keep fighting. But that's why it's so important to kind of just get people together and have a family meeting, and for Mom to say, hey, this is really what I want.
Yeah, that's great tip. Thank you.
Yeah, I have one question. Hi, this is John, Absent Medicals Internal Medicine. We had a patient on our floor. It's kind of complex situation. I believe Dr. Lux is following this patient in the ICU right now. So the patient decided to go full code after she had a out of hospital DNR, and she's currently intubated, or she was extubated recently, but I believe her daughter wants to flip her back to DNR. So how does it work? I know that you just said that we cannot flip the patient back to DNR if they signed a full code, but she actually didn't sign. She did it verbally. She reverted herself back to full code when she was extubated initially. So how does it work?
I think I was thinking if they've signed themselves DNR and then later tries to flip them to full code, it can't be that way. Does this patient have capacity right now? Does the patient have capacity?
Yeah, so according to Dr. Lux, she does have capacity to make her own decisions. And that's when we changed her back to full code when she was on the floor. So we made her full code, and then she went to the ICU. She was intubated, and I believe during when she was on a mechanical ventilator, the ICU team called their daughter, and daughter wanted to make her DNR again because she had this out-of-hospital DNR, but still she made herself full code when she was in hospital.
And so
it was kind of really complex.
Currently, she doesn't have capacity.
Well, so when she was intubated, she was on sedation, so she cannot take her own decision. But once she was on the floor, Dr. Lutz believed that she has capacity to make her own decisions.
I guess it really depends on what her, a capacity can change from day to day.
Mm-hmm.
So if she does not currently have capacity and is sedated, then the daughter can reverse it.
Yeah.
But, I would, I think there's reducing sedation to see if she has capacity now. I would, we would want to make sure,
And people can have capacity even on, ventilators, and it's a little bit more difficult of a conversation, but it can be done to see if they have capacity.
Okay, so if she doesn't have capacity right now, but she previously made herself full code in the hospital stay, can we still make her DNR again according to her daughter's wishes?
If the daughter is the surrogate maker, yes, you can. If the herself does not have capacity right now.
And then that should be documented, especially in the primary team is the team that needs to document capacity. So capacity, like our legal department will say, capacity is assumed. So if you capacity, it needs to be documented. Primary attending note that the patient has capacity.
Yeah. Okay. Thank you.
Thank
All right,
you.
you're welcome.
Did that help? I hope that helped.
Yeah, I did.
All right, anybody else?
Is it?
All
Thank
right,
y'all.
well, thank you for listening to us today. I appreciate it.
Thank you very
Thank
much.
you.
It was great.
Thank you.
Thank you.
Thanks, everybody.